Good afternoon, good morning, and good evening to colleagues around the world. Thank you so much for joining. You are now joining another event of the WHO webinar series on clean air for health, from evidence to solutions. So my name is Heather Darohani, and today I'll be the chair of this session. I'm a technical officer at WHO working on household energy and health. Um, so I'm really honored to be here today to chair a webinar about Together for Health. We stand with science, country data, and SDGs on air pollution health, building on the theme for WHO's World Health Day. So we're really trying to advance and share information and insights on how we as WHO are really looking at air pollution exposure and calculating disease burden to really drive policy change. This meeting will be recorded for dissemination purposes. Please use the Q&A box to type your questions, which will be addressed as much as possible during the session. And just to flag what we're aiming for within this webinar is we want to present and launch new data for SDG 3.9.1, SDG 7.1.2, and SDG 11.6.2. We're also going to highlight country involvement in the monitoring and reporting process of the SDGs to really show how we at WHO are trying to ensure that there's true ownership and by the countries of their data that was being reported. We're also going to spotlight regional plans, national actions to really tackle the significant health burden associated with air pollution. So now it is my great pleasure to share the floor with Mr. Bruce Gordon, the Acting Director of the Department of Environment, Climate Change, One Health and Migration at WHO headquarters. So over to you, Bruce.
Thanks, Heather, and welcome everyone. I'm really excited to be here for all the reasons Heather said, and especially because air pollution is such an incredibly important determinant of health. And some of the changes that we can influence and promote through a monitoring effort of the SDGs is actually very substantive. And let me tell you, I come from a water, sanitation, and hygiene background, and one of the most powerful levers I think that WHO has is monitoring. And in particular, it was the old MDG framework, the Millennium Development Goals, and now the Sustainable Development Goals. And I think when countries see what their status is and whether they're and how they do against their neighbors, sometimes they are compelled to make very significant investments, and they build that political will necessary to make the changes I think that we really need to make. So some of these changes are, they're system-wide changes, and they require national targets, they require policies, governance, regulation, the whole ambit. And it's really kind of the foundation for doing that is understanding, where we are and what ambition we see and the opportunities to prevent disease. And in this case, quite a bit of disease. We'll talk about that later through monitoring. So as Heather mentioned, I think it's also important that there's ownership in these figures. And that comes with being very transparent about how they're derived, having credible methods, and again, transparent definitions and harmonized methods. And so with all these together, we can kind of collectively understand, where we're heading. And I think everyone would feel ownership and over these. The other part I think that's important is this issue of being able to collectively review them. And I'm happy to say, and as many of you know, at the HLPF in New York, which is coming up very soon, where there is a global review of the SDG 7 and 11 targets. So our targets. And hopefully there will be some good, constructive, and productive discussion among member states on how to accelerate progress. So my last point, because I know we have a packed agenda, is the issue of, again, I think maybe Heather, you mentioned it, but relating some of this exposure data that we're seeing to health outcomes in the form of SDG 3.9.1. But it's just to note that this is a core health issue, but at the end of the day, much of the work that's required to reduce the health burden is outside of the health sector. So it's very important to have, these data that are very clear about the health impacts, but also on the exposure so that we have true multi-sectoral work done together. I mean, you know that WHO member states, obviously from around the world, have agreed to a target of reducing by 50% the health impacts of air pollution. And that's why we're here today. We're going to monitor it closely. And we look forward to working with you to accelerate progress to the end of the SDG period, then onwards in a post 2030 framework. So with that, wish you the best in your meeting.
Wonderful. Thank you so much, Bruce. So as it was very helpful to lay in that kind of framework for what we're going here with this webinar. So now, as we alluded to, we're going to kind of take you on a journey through how these estimates come. You may see a number at the end, but it actually takes a number of different building blocks to get to that number. And it involves everything from understanding the background disease rates to actually understanding exposure, working with countries to understand these numbers and incorporating their data, and then really finally producing that number that everyone can support and track progress with. So now we're going to turn to, we have a video presentation from Dr. Bochin Chow. He is the statistician from the Department of Data, Digital Health Analytics, AI at WHO headquarters. And Dr. Bochin Chow, he's going to really present us how we derive the actual underlying disease estimates for estimating the burden of disease from air pollution. So we all start from a common pool of number of deaths and disability associated with each health outcome, but it takes a lot of work just to get that background disease rates. So we're going to take our first step, our first building block to learning how we get the disease burden calculations through this video. So we will now hand over to Dr. Chow. Oh.
Hello everyone, my name is Bochin Cao. I'm from WHO's Department of Data, Digital Health and Analytics and AI. Today it's my pleasure to present to you an overview of WHO's global health estimates, which is WHO's tool to monitor global health and burden of diseases. Let me start with the introduction of what are global health estimates. Global health estimates, what we also call GHE, represents WHO's official comparable estimates of mortality and loss of health by country, sex, year, age, and pulse. It reports on annual health outcomes for over 170 diseases and injuries for WHO member states from the year 2000 onwards. Currently, the latest available estimates are up to the year 2021. We are currently in the process of updating the time series to the year 2023, and we expect to release the updated estimates in the next 2 months. Data. What are global health estimates? Global health estimates, what we also call GHE, represents WHO's official comparable estimates of mortality and loss of health by country, sex, year, age, and pulse. It reports on annual health outcomes for over 170 diseases and injuries for WHO member states from the year 2000 onwards. Currently, the latest available estimates are up to the year 2021. We are currently in the process of updating the time series to the year 2023, and we expect to release the updated estimates in the next 2 months. In general, GHE consolidates and harmonizes the best available data from multiple sources, including national vital registration data, which we use as a
Give me
primary
a bit
source
more
for
details.
cause of death data. And we also
The
draw
GHG
estimates
reports
from
on
WHO's
disaggregated
technical programs
mortality and
from
morbidity
UN partners and interagency
for
groups,
183
as well
WHO member
as
states with population
estimates
greater
from
than
the global
90,000,
burden of
and
diseases and
estimates
other
are
scientific
reported
studies.
separately
In
for men and
estimating the burden of
for
diseases,
years from
we
2000
apply
onwards,
a variety of
and the estimates
demographic,
are available
and
for
epidemiological methods
170
based on the
individual
best
causes,
scientific evidence
which we
available.
group. Give you a bit more details. The GHG reports on disaggregated mortality and morbidity data for 183 WHO member states with population greater than 90,000, and the estimates are reported separately for men and women for years from 2000 onwards, and the estimates are available for 170 individual causes, which we group into three broad categories. The first category being communicable maternal, perinatal, and nutritional conditions, and the second being non-communicable diseases, and third is injuries. And the estimates are also reported by age groups, and start from 0 to 1 and 1 to 4 years, and then from there on largely 5-year age groups up to age 85 plus, which we use as an open age group. And we also report some data estimates for some related indicators as a byproduct of this exercise, and that include the assessment of completeness of death registration data and life expectancy, healthy life expectancy, as well as years lived with disability and disability adjusted life years as a measurement of the overall burden of diseases. And the GHG data has some important usage, including monitoring numerous health-related indicators that are pertinent to the Sustainable Development Goals and WHO's 13th and 14th General Program of Work. And those indicators include child and maternal mortality, premature mortality due to NCDs, suicide mortality, and mortality due to road traffic injuries due to homicide, natural disasters, and conflict. And the GHG data are also used as input data to serve as an envelope for estimating mortality attributable to risk factors such as tobacco smoking, air pollution, and wash. The GHG data is very critical for member states and WHO to understand the global health, its trends and shifts in main causes of death by region and by country. And it can be used by decision makers to guide policy making and resource allocation. The GHG data are also important inputs to WHO flagship publications, including the annual World Health Statistics Report and Global Monitoring Report for UHC. And now let me give you a quick walkthrough of the estimation process for the GHG. There's 3 major stages for the production of GHG. We start with getting input data. At this stage, we identify and extract data from a variety of data sources that meet our specified data inclusion and exclusion rules to make sure our estimates would have high quality. And the second stage is estimation. At this stage, we address the data biases and comparability issues. For example, the underreporting of cause of death and the misclassification of cause of death. By doing so, we can make sure the estimates would be comparable not only across geographic locations, but also over time.
And we would also need to validate the estimation strategy to ensure the final estimates from the statistical modeling would be as close to the reality as possible. And we also generate uncertainty for each of the point estimates we have during this estimation process. And once the estimation are done, we would start our dissemination process, in which we would start with a country consultation to engage with member states and make sure the estimates would gain consensus from countries as much as possible. And once country consultation is done, we will also add a statistical clearance to ensure that there are no human errors in reporting the estimates on the official and public domain of WHO websites. And along with the estimates that will be published on WHO website, we will also provide the detailed methodology. The whole estimations process starts from estimating all-cause mortality, which we do separately for countries with good vital registration data and countries without good vital registration data. For countries with good VR data, the estimation are fairly straightforward. First, we assess the completeness of those vital registration data, and then we make adjustments for underreporting accordingly. However, for countries without good VR data, we draw on the input data from census from National Representative Household Surveys and other data sources, and we use the modeling approach to generate the age and sex specific estimates for all-cause mortality. For the estimation of cause of death data, we rely primarily on the vital registration data from countries where possible, with adjustment for incompleteness and misclassification of cause of death. And for countries without vital registration data, we use the global burden of disease study as a complement source to fill the data gap. We also produce estimates of burden diseases measured by DALI as part of the GHE enterprise. For the mortality component, years of life lost, we calculate those using the cause of death estimates we derived in the previous slides that I mentioned. And for years lived with disability, we primarily draw on estimates from the global burden of disease studies. Similarly, we also produce estimates for life expectancy and healthy life expectancy, which are important indicators for WHO to track the overall population health at global, national, and regional level. And this concludes my brief overview of the GHE source of data and estimation process. Thank you very much for your time.
Wonderful. That was great to hear from Dr. Chow. As you can see, a lot of work goes into just understanding the disease spread that we have behind countries. And it's really important that we take their data and we work with other data sources to really understand what that background disease rate is. So we've established the first building block. And now we're going to move into a little bit more of a dynamic discussion amongst, we have a presentation with different presenters, and then we'll hear a bit more from countries, etc. While we're getting the presentation up, a few quick housekeeping things to remind you of. Indeed, as I noted at the beginning, this is recorded, and we will provide this recording to a broader audience at the end, and it'll be widely disseminated in case you're not able to stay for it all, or you'd like to share with your colleagues or friends. In addition, it's important to note that you as speakers, you as attendees, you will not be able to speak or turn your video on. However, we do really ask you to put questions in the Q&A, relevant questions to the topics at hand, and we will do our best to respond to you as soon as possible. And if in the cases that we aren't able to respond to you within the duration of this webinar, we'll be trying to follow up at the end and sharing some additional information. Also to flag, we are very, very fortunate to have this particular webinar being translated into both Spanish and Portuguese. For those individuals that are interested in the translations, please look at the little buttons on the bottom of your Zoom, and that should allow you to connect to the correct channel for your correct translation. Okay. With that, a little bit of housekeeping, and now that we have the basic building block, we're going to jump forward and learn forward how we're going to actually estimate the exposure to air pollution itself, what are the steps we take into, and how we derive the specific estimates. So next slide, please. There we go. We'll look across the different indicators. We'll look at first the SDG 7 indicator on clean household energy, SDG 7. Then we'll hear about the SDG indicator 11. So how do we estimate exposures for these two different types of exposure? And then finally, to bring those together to estimate actually the mortality from household and ambient air pollution, that mortality rate. And what are the special little calculations that we do to ensure that we don't have those overlap and things that work out. And then we'll discuss a bit about the reporting process and hear some summaries and lessons learned. Next slide, please. I have the pleasure of kicking off this initial presentation, then I'll be happily handing over to my colleague, Dr. Carolyn Kersing, so that she can present a little bit more on the ambient and methods, etc. So I'm going to kick it off, and we're going to first start with just giving you an overview of the indicators themselves, and I'll do a little bit about SDG 7, give you a little details there. As you can see, one of the first things that drives how and why we're even monitoring air pollution and the disease burden is we have to look at the environment, and how we can use that is looking at the environmental health pathway. The biggest and biggest opportunity to protect public health is to really tackle air pollution at its sources. We would rather have air pollution stopped at the beginning than having to create and provide guidance and ways to protect yourself from it. We do that, but the first thing is to prevent this from even happening at first. So we need to first of all look at the source of emissions and figure out how we can best approximate that to help us translate that into exposure. We do not have the capacity, nor does any country or person, to be able and go to measure the emissions from every single air pollution source, such as households, cars, etc. Rather, we need to create some way of approximating that. And then we'd use that a proxy for exposure. We're going to combine that with the evidence that we have, epidemiological evidence, to help better approximate the actual disease burden associated with that exposure. And we do that for specific diseases for which we have the strongest epidemiological evidence. At the moment, this includes communicable diseases, specifically acute lower respiratory infections, commonly known as pneumonia, as well as non-communicable diseases, including ischemic heart disease, stroke, lung cancer, chronic obstructive pulmonary disease, sometimes called chronic lung disease, and diabetes and mental health. These are those outcomes for which we have the strongest evidence, epidemiological evidence, and for which we are actually able to calculate. However, I think these estimates are just based specifically on those diseases, the first diseases listed, which is ALRI, IHD, stroke, lung cancer, and COPD. However, the evidence is growing more for diabetes and mental health. So basically, after we take our understanding of what are their emissions, what exposure this leads to, what are the proxies and indicators that we can use. Then we go ahead and translate that and apply those risks to the actual disease burden we just learned about to help figure out what this burden of disease is. This can help inform health impact assessments, which can really inform decision making. Next slide, please. So one key example of how we can do this is specifically for household energy use. And it is very difficult for us to go and measure measure every single fuel and technology being used by households, what air pollution that's exposed to, and how that leads to disease. That would be very expensive and laborious, and countries are already challenged with many, many tasks. Hence, we need to find some development of some proxy indicators. So we've done that for household energy use. And in fact, we have actually used our WHO guidelines to influence the SDG 7. So the SDG 7 indicator, which is helped to estimate the access to modern energy services, is the proportion of population with primary reliance on clean fuels and technology. And in the case of SDG 7, we do that specifically for cooking alone, because that's where we had the most data. Now, what do you say when we have data? We're specifically referencing what we can gather for. And that's not, like I said, going to every household. Rather, we use information that's included in household surveys and national census, specifically related to what fuels are used for cooking. In most cases, it's just the fuel. However, we are trying to get more data gathered related to this technology also being used to better approximate the actual emissions coming off the fuel and stove together, because it's really the combination that leads to the exposure. So WHO goes through and goes and does a systematic search each year through all the different household energy and national surveys, includes them in our household energy database, and that is gathering the data on what fuel is primarily used for cooking, because that's what the data allows us to do. And then we use that to approximate and use that as the proxy indicator for exposure to household air pollution. Now, this is likely a very conservative estimate because there are multiple fuels and technology being used in the home at the same time for cooking and as well as heating and lighting. And in many cases, surveys, for example, will maybe indicate that a household is using mainly clean fuels and technology for cooking, such as LPG, electricity, biogas, ethanol fuels, or solar cookers. However, but that's only the primary. So if they may be using, for example, an open fire just 20% of the time, but they're not reporting that, they're actually leading to a lot of exposure in the home. Hence, while we are very conservative when we estimate the disease burden associated with household air pollution purely based on the primary cooking fuel, because it's likely actually larger exposure due to that. Something finally important to highlight here is the importance about clean. This is an important part of how WHO is able to really help support the health sector, integrate and influence and engage with the energy sector specifically. As we have guidelines for indoor air quality, household fuel combustion, and these guidelines, the recommendations included in these guidelines actually define what clean is for fuels and technology in this indicator. So it is specifically dictating what fuels can be considered as clean and which fuels and technology combinations which we can consider to be polluting. Next slide, please. So these estimates are produced annually every year. We basically take the household energy database and model that to produce these statistics reported annually with other agencies at 3 of the SDG 7 tracking progress report. And as you can see here, we have data that scales back from 2000. We report all the way back to 2000, but looking at the SDG decades is usually 2010 to 2024. So that's the most recent estimates. And as you can see from this global trend of different regions across the world, in most regions of the world, the reliance on clean fuels and technology is increasing. However, with one exception mainly, and that is in sub-Saharan Africa, where we actually have population growth outpacing the access to clean fuels and technology. So we see actually an increase in the people using polluting fuels and technology and a decrease in the fraction due to this population rate pace outpacing the access to clean fuels and technology. However, we do see significant progress across all regions of the world, but also significant burden. For example, if you were actually to calculate the absolute number of people still lacking access to clean fuels and technology, the largest number still sits within the Asian region, although they've had significant progress over time. In any case, please check out this website and this fact flyer that gives you a bit more information. And now I'd like to turn to to Carolyn to share with us a little bit more information about how we do ambient. Over to you, Carolyn.
Thanks, Heather. So now that we know more about how we look at household air pollution, how we model that, let's take a look at ambient air pollution. So the SDG 11.6.2 is focusing on the annual mean concentration of particulate matter, so population weighted. And the reason that we model it is as many countries don't actually have access to this data, they don't do the monitoring. So in order for us to have these global estimates and for us to have for every country, we have to actually work with these countries and also work with additional types of data sets. So the monitoring is done generally 2 to 3 years, and this really is our proxy for trying to assess ambient air pollution. Next slide. So what data do we actually use to develop these estimates? The most important data is ground level measurements, and this is coming from official monitoring sites. So we work with countries, we reach out to countries, and we'll talk a bit more about that later, to get data from them. And this is needed in order to validate and to calibrate the satellite data. So we also work with the World Meteorological Organization to develop a satellite ensemble, which is really just multiple satellites being combined together so that we can have minimum overestimation or underestimation of fine particulate matter in different regions. And this is combined with population data. This allows us to then create good levels, so 11 by 11 kilometer concentrations of fine particulate matter for the entire world. And these are then aggregated, population weighted, to give you the concentration for a country for the annual mean concentration. So we also provide data at the city, town, and rural area. And the urban value that we provide is an aggregation of the city and towns. So the data is available from 2010 to 2023. And we recently launched the new air quality, ambient air quality database. So please check that out. That includes not just data from PM 2.5 and PM 10, but we also collect nitrogen dioxide from country whenever we have that country consultation process. Next slide, please. So if we look at what the progress is, so since 2010, we have actually seen declines in concentrations of fine particulate matter across different regions. Some progress is stronger than others. But what we've noticed is that after 2020, there's been a sort of a plateau, a stagnation, where there hasn't been much change in the levels across most regions, which is quite concerning. And in 2023, we observed that the number of people that are exposed to the highest WHO air quality guideline interim target, so that is 35 micrograms per meter cube. If you live in a low middle income country, your exposure is 13 times higher than if you live in a high income country. And all this data is presented in the fact flyer, which you can scan the barcode if you want to learn more information about each of them. Next slide, please. So now we're going to look at the mortality attributed to air pollution. And this is going to be the mortality that comes from both household air pollution as well as ambient air pollution. And this particular indicator uses an age standardized mortality rate. So it's estimated, it uses the data that was previously in the previous presentation by Botchin, the global health estimates. This is also reported every 2 to 3 years, similar to the cycle for SDG 11.6.2. And this indicator really allows us to have this proxy for air pollution exposure. Next slide, please. Next. So when we look at how these mortality rates have changed across the regions, we can see that it's very different across different regions, and the mortality rate is much higher in low and middle income countries versus high income countries. And in some regions, you have a greater emphasis from causes from acute lower respiratory infection, as opposed to having impact from strokes. So the input data to develop this, as I mentioned before, is using the global health estimate, which gives you the background data, gives you the background disease burden. And then we combine that with epidemiological evidence to develop the relative risk. And then combining those two together allow us to determine what are the number of deaths that are attributed to air pollution. We also provide, in addition to deaths, the disability adjusted life years of life lost. And these are available annually. The data is also provided on the Global Health Observatory, which is where you can find all of our data by country, cause, age, and sex. And data is available from 2010 to 2021, but we will be, as Bochin mentioned, they will be releasing new GHE data for 2023. So stay tuned for that. We will be providing updates soon. Next, please. So now that we understand what is the SDG data, how we use this data, how do we actually get this data? What is the reporting process? So integral to SDG reporting is working with the countries during this process called country consultations. So WHO liaises both with the country as well as the UN Statistics Division. So the UN Statistics Division provides us, through their consultation with the countries, the national focal points. So these are the national statistical officers that we then are given that information, and we liaise with them to then request technical focal points from the ministries of health, environment, right. Okay, perfect. So we liaise with these different ministries, and from them, we request both household surveys and census, and this is to support SDG 7. And then we also request air quality measurements from them, monitoring data, and this is supporting SDG 11. Once we get this data from them, we use this to develop these modeled estimates. When we have these model estimates, we then share these model estimates with these technical focal points for them to understand and to make sure that they agree with it and they validate it. And that's a really important process in that they get to see this data before this data is released. If they have any feedback during that time, we can make changes. Most of the time, we revise estimates when they give us new data. And once we've finished this country consultation process, we then share that data with the UN Statistics Division, in which case it's then published in the Secretary General's report. So this process really allows us the opportunity for the health sector to lead these multi-sectoral coordination, because as you can see, we have data that comes not just sometimes this data comes from the Ministry of Health, Ministry of Environment, or the Ministry of Energy. There's a lot of room for multi-sectoral coordination. Next slide. So just to summarize how this data actually feeds into the SDG. So we have three main databases. For SDG 7, we have the WHO Household Energy Database, and this data is coming from our National Statistics Offices. And this is the household fuel types and household surveys that feeds in, and these databases are online. So we also have the WHO Ambient Air Quality Database, which I mentioned previously that we recently updated. And this data comes usually from Ministry of the Energy or Health or the Ministry of Environment. This data is then stored publicly online, so you can access it. And then the last part of the puzzle is the mortality database, which is where you get the Ministry of Health, the death registration data. And all of this data is integral to us determining that value of 6.6 million lives being attributed, mortality attributed to air pollution. Next slide. So WHO, we know, are integral in air quality guidelines. We have helped define clean fuels and technologies and define clean air for health. And it's important to leverage the health voice when we are monitoring levels and trends and exposure and health impacts. This is not only important for developing an evidence base, but also to sort of encourage policies and planning. So the comparability of this SDG data is really important for us to now track countries' progress towards achieving WHO's proposed 50% reduction in the fraction of mortality that's attributed to our anthropogenic air. And this is our updated roadmap target. So this is something that countries are working towards. And, last point would be mainstreaming health decision-making is important. It's critical. And disseminating all the tools, the WHO tools that are available online, allows the health and economic assessments to be strengthened and to be considered in any sort of policy and planning and decision-making. Thank you very much. Thank you to all my colleagues. And here, these are some of the QR codes if you want to find out more information, both about the data, the WHO Global Health Observatory, the fact flyer where you saw a lot of the different graphs are from, and just general work that we do. Thank you for your time. Over to you, Heather.
Wonderful. Thank you so much, Carolyn. It's a great presentation and helped us really get a better sense of how it is that we estimate the exposure to these different sources of air pollution. So now let's take a little bit of a look at a regional perspective and how we can take these long-term trends in SDG data and how we can look at long-term impacts and really track progress. So we want to first start at the regional level. So we're going to get a little bit of a broader scope on how this is applied. And we will kindly turn to our colleague, Mr. Juan Castillo Luga, and he's a regional advisor of climate change and environmental health of the Pan American Health Organization. And over to you, Juan.
Thank you, Heather. Thank you, colleagues. For us, it's really exciting to be part of this conversation. We celebrate also the great effort done by all these experts preparing this update of the SDG indicator, but that also help us to track progress of what is being done in the region and globally. I'm going to switch to Spanish for this presentation. Most of my slides are in English, but I'm going to switch to Spanish. Estamos muy contentos de poder hacer parte de esta conversación y creemos que es muy importante resaltar el progreso que está ocurriendo y que la actualización de los ODS además nos ayuda a ver cuál es el progreso regional. Y yo quisiera mostrar en estas diapositivas un poco cómo estamos utilizando estos datos para avanzar la acción en la región. Agradecemos también la amplia participación en esta sesión. Y quisiéramos arrancar diciendo que el sector salud, digamos, estas mejoras en calidad del aire que han sido discutidas ahora en las tendencias que presentó Caroline, que se discutió anteriormente, no están pasando por casualidad. Están pasando como el resultado de una suma de diferentes políticas, intervenciones y particularmente el liderazgo del sector salud que está acelerando las transformaciones hacia un aire más limpio. En esta diapositiva estamos mostrando cómo la regulación en calidad del aire en la región está influenciada por metas de salud. Es decir, que cuando estamos hablando del desarrollo regulatorio en la región, y aquí solamente son algunos de los países que están desarrollando o han recientemente desarrollado nuevos estándares de calidad del aire basados en las guías de la Organización Mundial de la Salud, están utilizando el argumento de salud como un eje para acelerar esta acción para un mejor aire. O sea que esta no es una problemática que solamente se está mirando desde el sector ambiental, sino que el sector salud está teniendo un liderazgo muy importante para avanzar estas acciones. Aquí tenemos, por ejemplo, algunas políticas que están ocurriendo en la región, ¿no? Y vamos a tener el IANI en un par de minutos, pero tenemos la Política Nacional de Calidad del Aire y el panel VGR de Brasil. Cuando hablamos también de la integración con acciones de cambio climático y calidad del aire. Vemos como diferentes países de la región están incluyendo acciones de calidad del aire dentro de sus metas de mitigación, dentro de sus planes de mitigación de calidad del aire. Y esto no es solamente un esfuerzo aislado de un país, sino que es un esfuerzo que estamos viendo a lo largo de la región. Vemos también cómo las ciudades y los países están integrando acciones en sus territorios para mejorar la calidad del aire. Tenemos aquí a la derecha el ejemplo de Barranquilla, donde tiene una planificación urbana con enfoque en la salud que mejora la calidad del aire. Acá tenemos algunas de las intervenciones más significativas de la ciudad, como el pabellón, el malecón del río, que permitió la recuperación de una zona de una zona urbana, que ahora sirve para actividad física, que tiene buena calidad del aire, y también una recuperación de parques que permite que las personas tengan acceso a zonas verdes que les permita mejorar su actividad física y tener mejores condiciones ambientales. Y en la parte de la izquierda vemos el Plan Integral de Calidad del Aire, Salud y Cambio Climático de Trinidad y Tobago, país que, por cierto, ha recientemente iniciado el monitoreo de carbono negro como parte de sus actividades de monitoreo de la calidad del aire. Y esos esfuerzos reflejan este cambio, es el motor que está generando este cambio en las concentraciones que estamos viendo y que por supuesto necesitamos acelerar aún más la acción, pero queremos resaltar que esto es posible porque está ocurriendo en la región por el liderazgo de ustedes en sus países. También en el tema de energía en el hogar que mencionaba Heather, vemos como esa mejora en el acceso a la energía en los hogares también responde a políticas estructuradas en los países y no solamente a un efecto de mercado. Vemos acá en la mano izquierda, al lado izquierdo, como la Dirección General de Hidrocarburos y Minas de El Salvador tiene un programa de subsidio hacia los combustibles limpios y la electricidad. Acá a mano derecha, el país Colombia está desarrollando un plan nacional de sustitución de leña y combustibles contaminantes para la cocción de alimentos. Y todos estos, bueno, quiero darles un mensaje pues, de dos partes. Por una parte es que ese trabajo que ustedes están haciendo en los países tiene un efecto en estos indicadores globales, que lo que ustedes están haciendo tiene un impacto para que podamos avanzar. Y por otra parte, señalar que ese cambio que está ocurriendo nuevamente no está ocurriendo por casualidad, sino que está ocurriendo por el esfuerzo que desde el sector salud y muchos otros sectores están desarrollando. En la región, además, tenemos un grupo experto en RQ Plus, una herramienta para la evaluación de impactos a la salud de la contaminación del aire, y que recientemente hizo el lanzamiento de su hoja de ruta, donde plantea cuáles son las actividades que está desarrollando para mejorar las capacidades regionales en la evaluación de impactos y en la influencia de políticas que mejoren la calidad del aire. Tenemos más de 180 participantes en la región, hemos tenido entrenamientos en persona y entrenamientos virtuales, incluido un entrenamiento en el campus virtual. Ahora, ¿hacia dónde vamos en la región? ¿Qué queremos hacer? Y esto es parte de las preguntas que nos empezamos a plantear cuando principalmente la Organización Mundial de la Salud también hizo la publicación de su hoja de ruta global en calidad del aire y salud. Y nosotros queremos reducir en 12% la mortalidad hacia 2031, que eso nos permite alcanzar estas metas de reducción que están planteadas en la hoja de ruta, mejorar la calidad del aire, mejorar actualizar la regulación de calidad del aire en la región y reducir las concentraciones de PM2.5. Y una de nuestras metas más ambiciosas, que es reducir, incrementar el acceso a energía limpia en los hogares, reduciendo el porcentaje de la población que utiliza energía contaminante para cocinar, ¿no? Para que en los próximos años más de 20 millones de personas tengan acceso a la energía limpia. Bueno, esta diapositiva explica un poco más esto y en este contexto surge la hoja de ruta regional para América Latina y el Caribe, en el que estamos buscando mejorar estos indicadores de calidad del aire, tanto a nivel nacional como a nivel de ciudades. Pero yo quisiera tomar unos minutos para señalar que este es un esfuerzo conjunto que se ha construido de forma consciente con los países, con los Estados miembros y con los expertos regionales. solamente también del sector de la academia, del sector de las organizaciones sin ánimo de lucro, la sociedad civil y de múltiples actores donantes que se han unido esfuerzos para que podamos preparar este plan. Arrancamos esto en la preconferencia durante la Conferencia Global de Calidad del Aire y Salud el año pasado. Tuvimos una sesión preconferencia, luego empezamos el desarrollo de la propuesta con base en esos expertos y tuvimos 2 sesiones virtuales de consulta y un taller presencial en México donde pudimos terminar la preparación de la hoja de ruta. Aquí solamente algunos ejemplos, un esfuerzo también de reconocer la participación de las personas, ¿no? Tuvimos más de 80 participantes en el taller regional representando 18 países. Luego tuvimos una amplia participación en las sesiones virtuales que se llevaron a cabo y el taller presencial en México a principio de este año, que además contó con la participación del centro colaborador, del centro colaborador que tenemos con el Departamento de Salud Ambiental del Instituto Nacional de Salud Pública de México y diferentes aliados estratégicos. Y es un esfuerzo, se puede sentir como dónde está Waldo, pero es solamente un esfuerzo para reconocer diferentes rostros que han hecho parte de este proceso, de los especialistas y de muchos otros participantes que hacen parte de esta conversación. Para decir que eso no es un proceso que solamente construimos en una oficina, sino que es algo que es un esfuerzo regional del cual estamos muy orgullosos. Y con base en esto preparamos la hoja de ruta en calidad del aire y salud para América Latina y el Caribe con 5 pilares estratégicos. Liderazgo del sector salud, sistemas de monitoreo e información, políticas integradas, concientización y involucramiento de actores y financiamiento sostenible. Este documento acaba de completar la consulta y ahora estamos en el proceso de publicación. Nuevamente, eso está alineado a la hoja de ruta global de calidad del aire y salud de la OMS, siendo la estrategia de implementación para las Américas. Entonces, algunas de las actividades a desarrollar en el fortalecimiento del liderazgo y la capacidad del sector salud es ejecutar programas de capacitación, establecer mecanismos de coordinación intersectorial e integrar el apoyo técnico para avanzar en los estándares de calidad del aire en la región. Queremos además impulsar políticas integradas y estrategias de reducción de emisiones. Me faltó la diapositiva 2, veo. Donde queremos desarrollar planes integrados de calidad del aire, cambio climático y salud, apoyar las acciones regionales las acciones de los países para tener cocina y calefacción limpia e integrar los contaminantes climáticos de vida corta o supercontaminantes en los planes de acción climática. Además, promover la concientización, la comunicación, la participación comunitaria con un enfoque de equidad, de modo que este mensaje trascienda las audiencias técnicas y tenga también injerencia en el resto de la población. Y que tengamos particularmente sistemas de calidad del aire en tiempo real con alertas a la población y que podamos fortalecer la participación comunitaria. Y finalmente, asegurar el financiamiento sostenible y los mecanismos de cooperación regional. Nuestra meta como región es que podamos avanzar hacia una calidad del aire mucho mejor para la salud de las personas. Lo que los datos nos muestran es que es crítico lograr mejores condiciones de calidad del aire si queremos cumplir las metas de salud pública regional. Por eso celebramos el esfuerzo de poder tener estos datos que nos permiten tomar decisiones y el esfuerzo de los países en avanzar en esta implementación. Muchísimas gracias. Muchas gracias también a Giovanna Saavedra por su colaboración en la preparación de esta diapositiva. Heather, back to you. Thank you.
Many things, Juan, and very exciting to hear all this great work happening in the region. And I do believe we have one more speaker to highlight some of the national work going on. I'm very pleased to invite Ms. Eleni Ignatius to join us. She's the General Coordinator of the Environment Health Surveillance at the Brazilian Ministry of Health. Eleni, are you there?
Yes, thank you very much for this invitation. Well, my slides are in English.
That's okay. We have interpretation. Go for it.
Well, I speak Portuguese. Of course, it's easier for me. I will just present what we are doing in Brazil and em português. Eu vou apresentar o que estamos fazendo no Brasil em relação à qualidade do ar e impactos à saúde. Neste primeiro slide, eu trago para vocês as nossas estimativas em relação à mortalidade geral. Nós estimamos, no último triênio, uma média anual de cerca de 100 mil mortes, entre 95 mil e 100 mil mortes anuais, em razão da exposição à poluição atmosférica, especificamente em relação ao material particulado fino. Nós temos estimativas não apenas em relação à mortalidade geral, mas também em relação às doenças circulatórias, respiratórias, e algumas doenças específicas que eu vou comentar mais adiante. Essas estimativas, elas são referentes à exposição ao outdoor, ou à poluição ambiental, e não considera o impacto decorrente da exposição indoor, que nós estimamos cerca de 10 mil mortes anualmente. Em termos de medidas de exposição, como nós trabalhamos no Brasil? Para estimarmos os impactos da exposição indoor, nós usamos os resultados da Pesquisa Nacional por Amostragem Domiciliar, nós chamamos de PNAD, realizado pelo Instituto Brasileiro de Geografia e Estatística, que pergunta, por meio de amostragem domiciliar, o combustível prioritário usado na cocção. E então, considerando o uso de combustível sólido, prioritariamente lenha e carvão, em algumas áreas do país, nós podemos identificar um padrão espacial muito bem definido de áreas que fazem uso prioritário de combustível sólido para cocção, particularmente na região Nordeste, nos estados do Maranhão e Piauí. Enquanto que, para a exposição da poluição outdoor, nós usamos dados de reanálise do CAMS, que são apresentados, nós sempre usamos os dados de reanálise, mas que atualmente estamos apresentando por meio de um dashboard, de um painel definido como CISAM, que é uma parceria do Ministério da Saúde com o Instituto Nacional de Pesquisas Espaciais, o INPE. Estimamos a fração atribuível em termos populacionais ou em termos absolutos, por meio do uso de um risco relativo definido a priori pela OMS, por meio de meta-análise, e também definimos o percentual de população exposta a depender do tipo de poluente. Bom, então, em termos de o que estamos vivenciando nos últimos anos, aqui por regiões do Brasil, nas primeiras barras, o Brasil, nos anos de 2022, 23 e 24, 22 em verde, 24 em azul, nós observamos que em algumas regiões do Brasil, o ano de 24, nós tivemos uma taxa de mortalidade mais elevada que 23 em todas as regiões e no Brasil como um todo, mas também em algumas regiões mais elevada que no ano de 2022. Então, essa taxa de mortalidade, ela agrega o impacto da poluição outdoor e indoor. Então, o que estamos vivenciando no Brasil é uma redução do uso de combustível sólido em 16%, considerando 2022 a 2024. Portanto, o impacto no agregado aí no Brasil é menor, em decorrência da exposição indoor. No entanto, o ano de 2024, nós vivenciamos incêndios florestais em grande parte do território brasileiro. Isso quer dizer que eu acho que os slides, vocês estão vendo eu passar os slides? Perdão, Heather? Eu estou projetando os slides.
We just had some move, yes.
Yes?
There's a little delay.
Ok. Então, nós tivemos um maior impacto na taxa de mortalidade em 2024 em razão da exposição outdoor. Então, a taxa de mortalidade que combina a exposição, o impacto da exposição indoor e outdoor, resulta nessa flutuação de dados ao longo desses 3 anos, mas nós sabemos que está havendo uma redução do uso de combustível sólido. Então, em relação a 2022 e 2024, houve uma redução de 8,9% no uso de combustível sólido para cocção. No entanto, houve uma piora da qualidade do ar, da média anual de qualidade do ar, em grande parte do território, especialmente em decorrência de incêndios florestais muito marcados no ano de 2024. Mas nós produzimos esses dados em relação aos impactos à saúde e também publicizamos os dados de reanálise de qualidade do ar por meio do painel Vigiar, que nós podemos ver no Brasil as médias anuais, médias mensais, nós podemos observar também percentuais de dias acima dos parâmetros desejáveis, definidos pela OMS, tanto pela OMS quanto pelo Conselho Nacional de Meio Ambiente, e nós temos no Brasil um padrão muito específico de qualidade do ar, com as maiores concentrações, ou seja, a pior qualidade do ar vivenciada pelas populações residentes na Amazônia Meridional, no oeste do Brasil, especialmente na região do Pantanal, e também nas áreas metropolitanas de São Paulo e do Rio de Janeiro. Eu espero que vocês estejam vendo esse slide. Neste slide seguinte, nós mostramos, então, a questão da poluição indoor, né? Nós temos no painel Vigiar também uma aba relativa à qualidade do ar indoor, produto desse percentual de população que faz uso de combustível sólido prioritariamente, e também temos as estimativas de impacto na mortalidade. Também para homens e mulheres, além da população em geral. Recentemente, há pouco mais de um mês, lançamos um painel em parceria com o Instituto Nacional de Pesquisas Espaciais, que eu mencionei, denominado CISAM. A vantagem, então, desse painel é que nós temos um repositório, portanto, o usuário pode fazer download dos dados em séries históricas, inclusive dados meteorológicos também, além dos dados de reanálise, nós publicizamos também os dados de predição ou de forecast para 5 dias, de uma forma que facilita muito o uso por parte da população para além dos serviços de saúde. Então, o painel Vigiar faz uso de dados de reanálise produzidos pelo Instituto Nacional de Pesquisas Espaciais. E, além disso, semanalmente, nós produzimos boletins, informes, ou os weekly reports, com os dados nacionais de focos de calor, de estimativas de qualidade do ar, de dias seguidos. Esse boletim é por semanas epidemiológicas em relação à qualidade do ar, as populações mais vulnerabilizadas, o tamanho dessas populações por municípios brasileiros. Produzimos esses informes para todo o país. Além disso, participamos da produção, da aprovação de documentos que regulam os aspectos relativos à qualidade do ar. Então, participamos da Política Nacional de Qualidade do Ar, também da resolução do Conselho Nacional de Meio Ambiente, que define os padrões de qualidade do ar, porque somos membros do Conselho Nacional de Meio Ambiente. Esperamos a aprovação agora, nos próximos 2 meses, no máximo, da política nacional, né, do programa de controle de qualidade do ar, e também da definição de pontos dos padrões para os episódios críticos de poluição atmosférica, cuja participação do Ministério da Saúde tem sido fundamental. Finalizando, nós temos no Ministério da Saúde na Secretaria de Vigilância à Saúde, que nós denominamos Programa Vigiar, cujo objetivo é a proteção da população exposta à poluição atmosférica, a partir, naturalmente, de evidências científicas e de muita articulação intersetorial. Nós estamos em vias de publicação de uma diretriz que orienta os serviços de saúde em relação não apenas à vigilância, mas também à assistência para as populações expostas à poluição atmosférica, que está articulada com a organização do Sistema Único de Saúde brasileiro, em consonância com o Sistema Único de Saúde, e finalmente, oferecemos um curso de análise de situação de saúde bastante amplo para profissionais ligados à coordenação de programas de vigilância de populações expostas à poluição atmosférica. Então, já atendemos todos os estados e estamos em vias do lançamento de um curso para profissionais de saúde e também para gerentes de programa, técnicos de programa, em relação à poluição atmosférica e saúde humana. Bom, temos muito ainda a avançar, mas esse tem sido o nosso trabalho nos últimos anos. Muito obrigada.
Thank you so much, Eleni. It's great to hear the fantastic work that Brazil is really doing and really better measuring exposure, connecting that epidemiology, and really leveraging the health sector to serve as agents of change in policy and decision making. That's great. Congratulations, and thank you for sharing those experiences. This is wonderful. Okay, I know we're a bit past time, and unfortunately, it's been a very exciting and wonderful conversation, and we've had a lot of questions in the chat. I don't think we're going to have time at this point to do some Q&A live. However, please do look at the chat. We have answered some, and we'll do our best to respond accordingly after this if time allots. So, with that, I have the honor and privilege to turn now to Dr. Dermot Campbell-Lundgren, the Unit Head for Climate Change, Air Quality, and Health Unit at WHO Headquarters, to share a little closing remarks. Over to you, Dermot.
Thanks so much, Heather. Can I just do the usual check? You can hear me? Right. Fantastic, thank you. Well, thank you so much. Gracias, muito obrigado. I think obviously you've heard a huge amount of we think incredibly useful and powerful information from the global level through the regional level to the national level, and hopefully have been reassured that at WHO, we in partnership with the countries are fully on top of providing the best quality information possible on the monitoring of this hugely important risk factor. I think you all know that air quality is the largest environmental health risk factor that we have. It's one of the absolutely biggest health risk factors that we have, full stop. And we can't tackle this without having the best possible information on what the exposures are, what the disease burden is, and also what the trends are, including at the regional level and at the national level, and what we're able to do about it. And as I think has also been made clear in several of the presentations, action on air pollution overlaps very much with action to address the climate crisis. And so many of the same things that will help to solve the climate crisis will also save us millions of lives through improved air quality. And again, we need the best possible data to be able to do this. You've also heard, I think, the importance that WHO puts on working at the regional level and also consulting with countries. So, we're completely transparent about the methods that are used to estimate these indicators. So, we're open to refinement, we're open to improvement, but we really feel that countries can feel ownership over these data as well, and we hope that will also help to empower them to take the actions that many countries are taking. I think it's also clear as well that although there is a great deal that still needs to be done, and in some ways we've stalled a little bit at global level in the past few years, there are parts of the world which are making real progress on this issue. And again, we only know that because we're able to work with the best scientists to estimate what's actually going on with this risk factor at the global level. So with that, I'd just like to thank once again particularly the presenters from Brazil, from the regional office, and our colleagues here at headquarters, basically to encourage you to stay connected with us on this journey to address this hugely important risk factor, both indoor and outdoor air pollution. To recognize the importance that we have in tracking this in order to ensure that countries are serious about the very big commitments that they've made, particularly that big commitment to cut the burden of disease from air pollution by 50%. This is the kind of science and evidence that we need to make sure that we're working towards that. So I'll close there. I'll hope a colleague will post in the chat a link to the webinar series, because there will be more webinars in this series. And again, to thank you for joining us and hopefully staying with us on this journey. So over to you, I guess, Heather, to finally close off the meeting.
Wonderful. Thank you, Dearman. Indeed, I just skipped to a little housekeeping just to flag that indeed, as you noted, we would kindly ask you all to keep your eyes out on our website to look for more upcoming webinars. We will circulate this recording for everyone to see, and it will be available online. And please do check the chat. We have a number of great links to some of our resources, and there's a good pathway to a number of other resources. It's just a start. We've got a lot there. So thank you all for joining, and please stay tuned for more in the future. Thanks.
Thank you, everyone.
Thank you very much.
Thank
Thank you very
you.
much.